I am.
Are you
yes.
related to an ophthalmologist?
Yeah, my
Yeah,
mom.
That's your mom, okay.
Yeah, I
that's
called
what
her
thought,
out on
yeah,
Yeah.
It's like,
She's
So-
retired now.
So you're in Drucker's class, right?
Drucker,
Right, so you
yes.
guare both related to ophthalmologists.
Yeah.
Good, that's.
all right, why don't you
yeah.
present what Drucker discussed?
Oh,
Okay,
sorry,
good.
David.
Yep. Here's this here.
Because,
Oh my gosh, this is a really hard one.
yeah. Both my mommy and Dr. Bowie, neither of them had actually heard this before. So.
Yeah, my partner's not heard of this one either. That's why I sent you the review.
No pressure, no pressure.
So we'll get there together.
This is a good case. We have time actually, because two presenters didn't show up, so this is a
Okay.
cool one.
Okay, sounds good. There's a lot of imaging, so some practice for you.
Oh, great.
Okay.
I've been on TGH where we have no imaging. so-
Yeah.
Lots
There's
of
not too
it.
much imaging at the VA either. It's a lot of efficacy, but this is good for all the other stuff. Okay. So 73-year-old female diagnosed with POHS of presumed ocular hypoplasmosis syndrome in the past, treated with laser in the right eye, 1994 with vision loss. So that's why her vision's not good in the right eye. She moved from Tampa to Largo, started seeing Dr. Cohen. Her last injection in the left eye was in 2015 prior to moving. She had been treated intermittently in the left eye, but had been resistant to anti-VEGF injections, so presumably had some fluid. And then her vision is good in the left eye. These images are from April 2023, 1 month following a Vabysmo injection in the left eye. Medical history of thyroid disease, synthroid, and then VA 2200, but long-standing, not acute, and then 2025 or less.
What is the Vabysmo?
Oh, it's an anti-VEGF injection, but usually for wet AMD, but I guess just also.
It's not just an anti-VEGF, it actually doesn't say anti-VEGF anywhere in the package insert for Vabysmo. Why is that? Because it's not an anti-VEGF, it's a bispecific. It's the first bispecific ever approved for intraocular use. It's an anti-VEGF agent combined with an anti-angiopoietin 2 agent. Then there's a bunch of technical and access reasons that it's not classified as an anti-VEGF. It's classified as a biologic, but a bispecific. All the other commercially available injectables do say anti-VEGF somewhere in their package insert, but this does not.
Because it's both that
Yeah.
and also.
So I made up a new handout because of this, I give my patients, which is growth factor inhibitors.
Okay.
Yeah.
So I think eventually we may.
It's a growth factor.
Yeah.
Yeah.
Okay.
I think they're taking us to dinner soon, right?
Yeah, it was
Okay.
the Hurricane one.
I honestly
got
lost track of
canceled.
all of them at this point.
All right, so David, what do you got here? You gotta go fast with a lot of images. Not
Okay.
super fast, but.
So this is a color photo of the right eye. The vitreous looks hazy. In the center of the macula, looks like there's some hypopigmentation and some scarring. I'm not sure if it's NV or we're just seeing the choroidal
Alright.
underneath, but it looks like pose right in the macula.
So to me, it just kind of looked out of focus on the nerve and more like focusing on the RP atrophy. I don't know, Dr. Cohen. if you
Yeah, it's
think
tough,
it's
the
easy.
clarity you can't focus. So
Yeah, I think it's just out
it,
of focus.
I think it probably means that, and it's likely the eyes are myopic, or something.
Yeah,
something
so
off
that,
about
what I
the
took from it was the temporal crescent and then the RP atrophy in the macula, likely like myopic.
Color photo of the left eye. Nothing is really jumping out at me, maybe more of that RP thinning globally. The PP peripapillary atrophy inferiorly.
Yeah, and then maybe some like yellow smudged out lesions along the vessels, like maybe it's kind of hard to see in here, and then just the temporal crescent.
So since we have time, I'm gonna talk a little too.
Yes.
So this gets back to Dr. Beccaria's lecture, and you'll be asked, the patients are very upset. Does this patient have macular degeneration? Like, yes or no?
No.
No, and why not? But there's yellow spots. So there's 3, right? 1, 2, 3. They're within 2 disc diameters of the center of the macula.
But they're less than 64.
Yeah, they're small. And
Yeah.
they're also, to be macular degeneration, you have to have a number of these median.
20, and
Yeah,
there's only
20. There's only
4.
3.
Yeah.
So technically, the patient does not have macular degeneration,
Right.
which is interesting. And do they have ocular histoplasmosis?
Yes.
I don't know.
But that, no, so that was in the history, but then I didn't really see that.
Right,
and then that
there's
was
no
just like a history
peripapillary
thing.
atrophy,
But there's no
and the periphery has no pigment spots. I can tell
Yeah,
you.
and there was nothing even more zoomed out than this, so I was like, even if there was something, you can't really see it from these
And this
pictures
looks
at
more
least.
like atrophy than like the normal kind of like cigarette burn.
Yeah, there's
like,
like
Right,
punched out
right.
lesions.
Yeah,
right?
so again, it's pretty normal looking,
Yeah, exactly.
and this is a good eye, well, you know that.
Yes.
OCT of the macula,
The right eye.
right eye macula. The foveal contour is really cupped out, it looks like. Maybe that's not the right terminology, but it's deeply invaginated.
So the outer layers. Look, so that it basically is like a lot of disruption in the outer layers more so than the inner layers, but obviously, yeah, like a cavitation outwards and then some like overlap, I guess, would you call it artifact, like onto the, so you can't have a clear view of the choroid.
Looks
Looks
like
like
reverse
choroid's
shadowing.
atrophied as well.
Yeah,
Okay,
so
choroid's
it should be
full on that.
always
Yeah.
like going all the way back
So you got loss of the outer retinal layers and the choroid underneath.
and corresponding with the lesion we saw in the fundus.
Which was a laser spot.
Oh, the whole.
The right eye
both
had
those.
laser.
Oh, okay,
So the choroid and choroid capillaris are full of pigment.
yeah.
The RP's got pigment and your choroid's got pigment, so when you laser, that's gonna heat up and then it's gonna kill it.
Okay.
And then
Someone, yeah, someone lasered the whole.
Yeah.
Okay.
Which you did back then. That was pre anti-VEGF. I don't know what I'm curious what that lesion was pre-treatment, but
Yeah.
there was a subfoveal laser arm to the macular photocoagulation study, which suggested you should laser small lesions in the macula. And it might not have been subfoveal because the laser scars will expand over time.
Okay.
OCT of still,
No,
Left eye.
still,
what?
still,
Oh,
okay. There is some fluid,
It's right.
That's a left.
Left eye.
Here's a left eye.
It's a good idea.
Is this a vertical cut of the left?
Yes. You can advance with this and then he can point with the pointer.
Oh. So, can I move this?
You guys on the internet won't see him pointing, so they'll talk too. It's like, you can't remember that old cartoon on the internet, no one can tell you're a dog. That was a classic Far Side. That was the early days of the internet. It actually was a crossword puzzle clue.
so I see a fluid collection, subretinal and phobia.
And then some like deposits superior to the collection, hard to kind of tell what they are, but,
I just describe what they are in terms of
What they look like.
reflectivity.
hyper.
They are reflective. They're not as reflective as the RPE. Mid reflectivity.
Hypo or hyper.
Well, it is mid reflective. I wouldn't say, I mean, I'm looking at this area, it's
Mhm.
same colors, like the inner segment. There are speckles of hyper reflectivity.
Some people use the word sawtooth. It's kind of a code, yeah. They'll say
Refers to
sawtooth
this pattern.
hyperreflectivity, yeah, that pattern can be sawtooth.
Looks like there's a larger deposit of something here
Mhm.
and smaller depositions.
And this might be more because I like know the diagnosis, but maybe some elevation also, like right in the center. Like from where the line of the choroid is, you can see that a
You
little
know, you're
bit.
gonna give it away.
Okay.
Although I think
I don't think it's.
I don't think I'm gonna give it away.
So in the subretinal space, so what are your, what do you think that stuff is? In the subretinal space?
Blood or serous fluid.
There's fluid, the dark stuff's the fluid, the bright stuff, so your retina every day, again, getting back.
Photoreceptor
Yeah.
segments.
Yeah.
Yeah, last
shedding.
month, I can't remember, it's like $1 billion a year, it's over your lifetime, it was in my lecture, but I can't remember. Your outer segments just shed photoreceptors like crazy, and your retinas, your RP is supposed to pick them up, but when they're not opposed,
They collect.
those fluid spaces can get full of photoreceptors.
Can you use that to determine how long this has been here?
I don't think so, and you see it sometimes and you don't see it sometimes. It's more of a central serous thing
Yeah.
where you'll see it, or any serous detachment, but this does seem like a lot more than average. So, yeah, it's a little funny looking,
Well, funny looking.
yeah, it almost look like stalactites or stalagmites.
Mhm.
Goes down.
I forget which one goes down to.
All right, go ahead, you're doing good.
Another OCT kind of redemonstrating what we just saw, the subretinal fluid with the speckling of hyperreflectivity and deposition, sawtooth pattern, lumpy bumpiness.
Yeah. And then this OCT is obviously like tilted as well. I think if it were straight, then it'd be a little easier to see.
And this goes back before your time, but in the time domain OCTs, the initial OCTs we got when they first came out, the machine would flatten the back of the eye. So everyone was flat, but that was the machine doing it. In these OCTs, what you see is what you get.
Okay.
So in the spectral domain, and I think the same thing will be true of the swept source. So this is actually the contour. So if you were to do an MRI scan, or if you were to take your eye and slice it,
Mhm.
it would look like this. So this is a true picture of the back of the eye.
Is that implying that there's something deforming the shape of the eye?
Yeah, it's not a normal shaped eye.
Something's going on.
Yeah, something. Yeah, the shape's not normal, which is true in a lot of eyes. It's not everybody's perfect. It's, it's an imperfect.
So some helpful hints, for like what kind of photo this is.
The nerve is dark. Is that IR?
So this is, fundus autofluorescence. It's super dark. The hint is in the bottom left corner. But that's what was helping me with these, because obviously we're new to all this imaging.
What's the hint?
Oh, well, the nerve is like super dark, like darker than
And
it would be in FA.
And
but then
in the bottom left corner, BAF, you know what that means?
Something out of.
Blue light
Oh,
autofluorescence, which is very important to differentiate from green light autofluorescence, which you get on non-Heidelberg machines usually. BAF is blue light autofluorescence, which is a FDA approvable primary endpoint for developing geographic atrophy therapies currently.
And green light is not.
Green light is not.
Okay.
Wow.
Okay. So everything is hyper autofluorescent.
Yeah, right. Well, so there are two large areas of hypofluorescence, hypoautofluorescence. Right in the macula.
And it's kind of simple. There's two reasons you get dark in autofluorescence and two reasons you get bright. And when you think about it, it's obvious. Either have decreased signal or blockage, or increased signal and transmission. So in this case, it's either decreased signal or blockage. So what do you think it is?
Blockage because
Yeah,
of the.
no, other one.
Decreased signal.
Yeah,
Okay.
The vessels are blockage.
yeah, but the dark
Dark
spot,
spots.
because your autofluorescence, somebody want to help them where the autofluorescence comes from?
So
The color
autofluorescence,
picture.
my understanding is autofluorescence comes from the RP, like breaking down. So the hyperfluorescence is from like the breakdown pigment from the, like RP,
The lipo.
the lipofuscin, that's what I'm looking for. So as, the cells are actively dying, you'll get hyper autofluorescence. And then once you have full atrophy, then there's no more of the lipofuscin to reflect or to autofluoresce. So then it's, hypoautofluorescence.
Yeah, so
And at the edges of some hypoautofluorescence, you get increased hyperautofluorescence in one of a variety of patterns, which is perturbance of the RPE and accumulation of lipofuscin.
Yeah.
You don't see that here. This is non-hyper.
and we saw in the OCT, there was no RPE. So in the absence of
Right.
RPE, you're not gonna get autofluorescence.
Yeah. Right.
It's gonna flat. The other eye is more interesting because the RPE should autofluoresce. The other thing that can autofluoresce is the outer segments.
Mhm.
So if there's enough outer segments, you can get a little bright spot from that. All right, so this is kind of a fun photo. What do you see there?
So this is the autofluorescence of the left eye. And it looks like there are some areas, or one large area in the macula that's hypoautofluorescent. There's smatterings of other hypoautofluorescence. I'm not sure if this is artifact, but hyper autofluorescence.
That's probably real, and it looks like, what do we call those for the more senior residents, when they drip down like that?
Guttering.
Guttering, so that looks a lot like guttering,
Gutter.
you know? And hyper, so we talked about two causes of hyper, either an increased signal or increased transmission. What do you think that is? Got a 50-50.
Increased signal.
It's actually increased transmission. It's been a long time. It took me a long time to understand this. So for autofluorescence, the autofluorescent signal is your RPE. And then between the RP and U is the retina. So one way to think of it broadly is if there's less retina, you get more signal. You get a sort of a window defect. More specifically, the chromophores in the retina. So in your receptors, in your photoreceptors, are all these molecules that are designed to receive light. I mean, that's what they do. So when they receive light, they absorb it. So the same thing goes with coming back at you. So the autofluorescence signal should be absorbed by the chromophores in your photoreceptors. So a bright spot on an autofluorescence image usually means an absence of outer retina, which you can see in someone who's had a chronic serous retinal detachment. So if there's been fluid trickling down there for probably years, not necessarily decades, then the outer retina will slowly get damaged from that, and you'll see these little gutters.
I thought the gutters were like dark.
If it's there for a long time, let's say it's a central serous patient and so and the retina is just dead, then you get the dark.
So this is a fresh gutter,
This is a less severe gutter.
subacute gutter.
It's a gutter that didn't cause death of cells, but it caused damage to the outer retina. There's still RPE there, but the outer retina is kind of shot. But the autofluorescence is nice. I had a lady in yesterday who had cancer, very weird symptoms of peripheral flashes and probably vitreous, but there is cancer-associated retinopathy, which I've never seen, but it's out there. And so I got autofluorescence images looking for, broad loss of the outer retina, and it wasn't there. So, but autofluorescents are nice for looking for outer retinal damage. Anyway, so it's a fun image.
So for FA, we usually click through so you can see the different phases and then come back to the first one.
Yeah, sure.
Okay. I mean, this is the right eye, so, we're just kind of showing this. Here, okay. So the right eye, those are the three.
So those are typical laser scars. So if you're gonna do laser in the old days, which you're never gonna do again, you want it to laser hot enough to really kill things.
Mhm.
So you laser hot. So all that's left there is the choroidal vessels, and honestly, barely.
Yeah, and I think we'll see that in the ICG as well, but we'll get to clarify that. Okay, so yeah. The left eye. I'll click through a couple times. You can notice a little pattern there. Okay. So what was John?
And so this is FA of the left eye. It looks pretty. Is this the AV phase?
Yeah, so this one starts out already at 30 seconds, and you can, see that both arteries and veins are filled or getting there.
Nothing exciting yet. So I see some hyperfluorescence appearing here temporally to the macula. Looks like it's getting a little larger, so it's.
That's what I thought too, because
Give
it's
it
kind
a
of
little
getting,
more time.
yeah, okay. Well, and now the
Okay.
image is fading, yeah, so,
Okay.
but this was already at like 3 minutes, 40 seconds. So, yeah, I mean, that's what I thought, like it's smudging and getting a little bit large, increasing in size, but not clear borders, so I
That
call
whole
that
spot
like
there.
good. But other than that, I didn't see too much. And then it's now like almost 5 minutes. Anything else, Dr. Cullen, or?
No, it's pretty subtle, but that's what you get.
Yeah, yeah, so I think it's also pertinent negative, the differential. So. So ICG is how we view the choroidal vasculature. So that's like mostly what you're trying to see. That's what Dr. Khan was talking about in those areas, how really like it's so atrophied from the laser that all you can really see is maybe some of the choroidal vasculature, but even then it's like, clearly different from the rest. If we're just looking at choroid. And that's all that this is saying in the right eye, basically, from what I got.
Yeah.
Okay. So left eye.
So left eye, ICG demonstrating the choroidal vasculature. There aren't any focal lesions like the right eye.
And sometimes at that phrase that you would like a nice 1 minute one, because sometimes you'll see a branching vascular. If there's a neovascular membrane on the ICG, often you'll see it at about 1 minute. It's a little vascular network.
Yeah,
But so in that area where we were worried,
right.
I didn't see anything.
So yeah, I think then that was the important thing is that there was not a clear like vascular network.
And then later in the ICG, you'll sometimes see a plaque, which I don't think is really.
Yeah.
Is this the latest we have?
This is.
Yes,
that's
that
the
is.
way-
So,
pretty late.
I mean, I don't know, that looks like a vessel. There's that little bright spot.
Yeah,
Yeah,
Just there.
maybe like one.
kind of, yeah.
I don't think that's. a
And
plaque.
no clear like, what is it called, like in PCV, how would you describe it?
Oh, hotspot.
No, but yeah, clear like hot spot, like if you're looking for.
Like a polyp.
Yeah,
Yeah.
polyp.
Polyp, yeah.
Yeah, it's pretty benign.
I wanted to see one in that area where it
Yeah.
was leakage, but,
So unfortunately, no polyp for you, okay,
but we got the ditzel.
little ditzel.
Yeah.
little
But then you
ditzel.
have them here too. That's the thing. That's like looking at your hand, like you look like, oh yeah, sure, there's stuff all over the place.
It might be
Um,
patterned.
yeah, oh, do you wanna summarize it? I think I'll help you out a little bit with a.
Yeah, go ahead.
Okay, cause it is, mostly re-demonstrating the same like areas, in the right eye, like we have the atrophy and we know that we have the, or actually, do you wanna read it?
So for, what is the FP?
Fundus photography.
So there's RPE atrophy in the right eye and PPA, both eyes with yellow punctate lesions along small vessels in the macula of the left eye. On the OCT, there's a central serous PED in both eyes and a questionable elevation, or at least deformation of the macula in the left. On FA, there are hypofluorescent lesions in the right with hyperfluorescent borders, punctate hyperfluorescence with late leakage.
Yeah, and then I think when I was looking at the left eye, I kind of just called it, pretty normal for the fundus autofluorescence in ICG, maybe those little spots, but nothing like rip-roaring vascular network or, polyp. So, okay, so do you want to do differential from?
So the main thing of this case, like the 99% of this case is the woman's got one eye and she's got fluid in it.
Mhm.
So there's subretinal fluid. So the big differential is like, what can give you subretinal fluid in the macula in one eye?
Central serous.
Yeah, that's kind of the top.
Yeah.
And then what else? Cause she's older, right? She's not a guy.
Yeah,
'Cause she's a girl.
73.
Yeah, she's 73.
Do you have cataract surgery recently?
No, but subretinal fluid in an older person.
It's always on the differential.
Syphilis.
No. Let's say she was 85 or 90. It's mac, even though he said it's macular degeneration.
Okay.
Like, it's ocular
Wet
differential.
AMD.
Yeah,
Yeah.
it's just wet AMD is so common. So it's pretty much central serous wet AMD. And then there are other
Like
things.
polypoidal.
Yeah.
Or like a
Just kinda like
pachychoroid spectrum of disease, where it's kind of like chronic central serous and other kind of.
And her
You don't-
choroid wasn't that thick, but she was a myope, so
Right.
maybe. it was-
Yeah.
And you don't have the benefit of the other eye, so you can't tell if it's part of a symmetric pattern dystrophy. You
Right.
know, it
Right.
looks patterny, but
dystrophy.
you can't really call it that because you don't have the other eye.
If you connected to the disc,
Yeah.
it could be
Optic nerve
pit,
pit.
nerve
yeah.
pit, subretinal fluid from that. There's a bunch of drugs now. So you gotta check your drug list for the MEK inhibitors, all that stuff. And then, hypertension, choroidal I've seen hypertensive retinopathies with no retinal vascular. It's kind of a funny thing. I've never seen a paper on it. I was trying to get one of the residents to do it a while ago, we had some cases, but the difference between retinal vascular and choroidal vascular hypertensive retinopathy, because sometimes you will get just a serous detachment and the retinal vessels are good. I don't know why, I'm not sure why. And, yeah, that's mostly it.
Yeah, so, I
What
kind
about the
of,
shape? What about the shape of the macula on the OCT?
Yeah, that's part of it too.
so that's the major part of it.
Oh,
So, well, I'll go through some differential for this. So I called it, knowing the diagnosis already, a slightly elevated lesion in the macula in a myopic patient. So, like we were talking about myopia, posterior staphyloma. So, we'll go over the diagnosis on the next slide, but what I did was explain like why it is one thing versus the other. So, myopia posterior staphloma, if it looks like, you know, increased axial length and it's pouching outwards versus inwards like this was. Dome-shaped macula, we'll discuss that. CMV, there was no vascular network on, FA or ICG. Always a mass lesion if there's any elevation, like an amyloidotic melanoma, choroidal met, but usually you'd be able to actually see something in the choroid versus it, you know, looking the same on both sides. Of course,
Well, actually, nevus and
Oh, yeah.
neovascular membranes, they're kind of funny and they can leak some. That's a
Yeah.
good one.
So CSCR, where you would get, like, I think we were just talking about diffuse choroidal thickness instead of like just in certain areas. And then this tilted disc syndrome, which I don't think they're necessarily too tilted, but there you get inferior thinning instead of like the thickened choroid. So this is dome-shaped macula. So this is an this is an OCT diagnosis largely. It's a new diagnosis as of like 2008. Dr.
Dr.
Gaucher,
Dome.
yeah. Started kind of, you know, talking about this diagnosis, and even the pathogenesis was a little controversial, but basically it's a dome-shaped elevation seen on OCT, typically within a region of posterior staphloma and high myopes. Usually they're like greater than -6 and then axial length greater than 26.2. So you have this bulge of the RPE choroid and sclera greater than 50 micrometers in height compared to the surrounding RPE. And you have to get vertical and horizontal cuts because it's a dome, because the way it's characterized is like there's subtypes based on like horizontal, vertical, or both, basically. Like I said, the pathogenesis is a little controversial. It seems like the most common opinion is that it's kind of like a response to the increased axial length of the eye to like pouch inwards to decrease the axial length, to, you know, like focus the light a little bit better, like the inward pouching. That's the most commonly agreed upon.
So it's kind of like a localized pachychoroid spectrum.
Even the sclera, it's not just.
It's
the
everything,
choroid,
yeah.
Everything's kind of pushed
With
over.
the sclera, bunch of
How is
inward.
it mechanically moving inwards like that? Like, is there something pulling it? Is there something pushing
Well,
it?
the eye shapes, there was somebody just published a thing on eye shapes kind of a month or two ago in one of the journals, but if you do eye shape analysis, there's a bunch of different shapes. I think they had 5. You know, with the myops where you get the staphloma, where you get the tilt, or you get the inferior, and this is one of the shapes where you get bigger, but then you squish in a little.
Yeah.
I think it must be
Must be
something about the
mechanical.
mechanics.
Yeah.
I can't imagine. the
Not
device
really
that
any
small.
membranes talked about, like
Right.
strong enough to pull, including the sclera in.
It's like a reverse staphloma.
Yeah, it's like an inward pouching within the whole staphloma and this usually like in the center area. And then, so the big thing is they can have associated subretinal fluid and subretinal fibrin, which can mimic the CMV that we're more used to seeing. And that's really like the mainstay of treatment as well, because there is no proven, you know, effective treatment for dome-shaped macula. You just want to control the SRF, and often it'll resolve and then recur, like we're gonna see with Dr. Cohen's patient. Your options are anti-VEGF, like how you normally do subretinal fluid. There is the option for PDT if you're treating it more like a CSCR kind of picture. However, the fact that it kind of fluctuates with or without treatment, as we'll see with this patient, for her, like initially she had failure of anti-VEGF, like she's been getting injections since 2015, but she got Vabysmo and then she came in 6 weeks later and her macula was better. So initially they were gonna do PDT, but then her macula was better and it was canceled. And then this is just showing like her OCTs over time, that the fluid kind of comes and goes without treatment. And her vision is like very good in that eye. It's
Even
2025.
with the fluid.
Yeah.
She's totally
so-
asymptomatic with the fluid.
Yeah.
Doesn't notice anything.
It's pushing
So-
the retina even further.
Yeah, so maybe, exactly, yeah, maybe it's just pushing the retina even further, so now it's just kind of helping her.
It's refractive.
Yeah.
Yeah, so anyway, it's basically just showing kind of comes and goes
Yes,
over
that's
time.
2023. Yeah, that's the year of 2023.
Yeah,
This is coming. And some of these are treatment, some of them aren't. You just get
Yeah.
better and worse.
that's it.
Oh, so that paper, so the paper had a couple other things. In the paper, the review, which was, I think, Survey of Ophthalmology. Did I say-
Yeah, the 2020.
Survey of Ophthalmology had a review of it. They showed that they had 60 or 80 patients. It was not a small, it wasn't 10. It was a decent, for this diagnosis, it was a lot of patients. That's why I thought, oh, that's a good paper. And they showed this waxing and waning no matter what you did. So it was with or without anti-VEGF, with or without PDT. It just sort of came and went, which is what I think is driving me crazy. with her, because it's hard to tell if she responds, because I think she might just be waxing and waning. So on the last visit, I just did nothing. So I thought, because nothing we do has no risk, everything we do has a risk. And so the shots have a small risk of, it's her only eye, it's hard because it's her only eye.
Yeah.
So the shots have a risk of infection. I was about to PDT her, and I thought, let's just watch it for a while, based on that paper.
Yeah.
At least it's not named after somebody.
Yeah, the dome shape. It's either.
Yeah.
Yeah,
Great.
And okay, so the other thing is that paper, it's coming back to me, is what's interesting is that if you look at myopes, dome-shaped macula is pretty common. I want to say they said there was 10 or 20% of myopes had the dome.
Yeah.
And then the other thing is, if you look at domes, subretinal fluid's not uncommon. So I think it was 1 or 2%. It was more than 1% of domes had fluid. So you're gonna see this. So that's the thing, even though it's weird a number of my partners, David, of course, heard of everything, but a number of my partners hadn't heard of it, like people haven't really heard of it, and people are kind of banging their head against the wall. And now with OCTs, everybody's, you see fluid, you shoot.
Yeah.
Yeah.
But I think this is gonna maybe come up to be more, I wish someone would figure out, because I talked to Scott about it a bunch and some other docs, and I don't know where the fluid's coming from. So it's hard to know how to get rid of it. Fluid's gotta come from somewhere. I mean, it can't just appear. It's gotta either be from the vitreous, the retinal vessels, or the choroidal vessels. I imagine.
Thinking it's coming from the choroidal vessels.
Yeah.
Yeah.
You have the
have this
pappy
localized thickening next to thinning, so it can almost be almost like a central serous with choroidal thickening causing the fluid buildup.
Right, yeah, I think the fact that PDT doesn't seem to help, I think is maybe just that it's rare and people didn't do it right. You wonder, because I was ready to PDT that area, that infratemporal area. I thought, man, if I hit that, I'll bet that'll help with maybe half fluid, something
It
like
probably
that.
would help, I would think.
I think it probably
It seemed
would.
like it would.
That'd probably be a next step.
Yeah, that'll be, if she doesn't keep doing this or gets substantial to her, so I'll probably do the PDT. But
You have to cut it
it's
this
gotta
way,
be done.
AMD though.
Right, you gotta clear that. But that's this. We had 2 presenters not show, so we're kind of done. I
Well
have
done.
a case that's interesting, but I want to save it for you guys to present.
I'm gonna head out. I gotta do my.
Any questions or anything?